Thanks, Dan. And good morning, everyone. It's very nice to join you, although remotely it seems very odd. I can see you in the room. And I hope this will add to what Nicholas has talked about, because he and I seem to have worked in the same spaces, very different environments and different pathways. But my career has indeed been focused on trying to achieve integration of care. And like him, I have the examples of one in my life about how we don't actually provide coordinated care and why it needs to be a priority. So as Stan said, I'm here to talk about a particular report, a report that was commissioned by the Australian College of Emergency Medicine. They asked us to look at why people needing mental health support in acute mental health crisis get stuck in emergency departments. So that's what I'm going to talk about. I'm going to add into my reflections a couple of things that I'll speak to very quickly. One is I do have some degree of a mental health background. For 3+ years, I led the Commonwealth Department of Health's mental health program, and that included, at the time, the rollout of the Better Access to Medicare program, which is still going on and which has had its troubles because of its original design. And I reflect with great feeling on Nicholas's reference to professional territories, which are in abundance when you are trying to develop health policy within a health policy department. So I've got that background. And I have also done some recent work, published in 2021, I think, called Equally Well, Being Equally Well. And that was an inquiry into what are the system changes we need to achieve the integration of care for people with serious mental illness and comorbidities that are either preventable or need better management, physical comorbidities. So I think Nicholas and I could have swapped places. I could have talked about the Being Equally Well program, and I concur with absolutely everything he has said to you today, and particularly that only in Australia could you have a platypus of a health system. Before I start talking about the Nowhere Else to Go report, let me also acknowledge the traditional lands on which I am sitting to meet you today. It's the land called Naarm of Melbourne, which is the traditional land of the Kulin Nations, who are the traditional owners of the university land where Victoria University sits, where I'm meeting with you from today. And I'd also obviously like to acknowledge the lands that we all sit on. It's a very precious country. So why this report? I will also start by saying I have got jam-packed slides for you, because in being approached to talk to you at this conference about the report, and as Stan's just identified, the report itself is what is important to you, not what I say about it. So I have done the slides as a high-level summary of the report to entice you to think about it and to see what you can do to help make the changes we need to create, because I want to talk to that as well. So why this report? Emergency departments are often considered the canary in the coal mine. They shouldn't just be considered, they are the canary in the health coal mine. It's where you go when there's nowhere else to go. And if you're in an acute health crisis and it's late at night, or it's even during the day now, where else to go? You can't get a general practice appointment. You may not even have a general practitioner home. These days, if you cannot see a doctor and you have something that is acutely troubling you, there is nowhere else to go but an emergency department, which is stupid. It's high cost, specialised care, and we're going there with broken arms and so on. And so it's not at all surprising that people in acute mental health states present to emergency departments all around the country and every day. But what is of concern is that It's very clear from the experience of emergency medicine physicians and others that what happens when people with a mental illness arrive at emergency departments, they stay much longer than anyone else with poorer outcomes. And that's what led to this report. A meeting of delegates to the ASM Australian Summit on mental health care called for this work to be done. We facilitated that summit, having started working with the College of Emergency Medicine at the time. This is the data. I won't talk to the slides. I will leave them with you, but it's easy to see that there is a serious discrepancy, inequality, you could call it many things, for people with serious mental illness who arrive at emergency departments. What's much more troubling than any, I think, is they are more likely than other patients to leave the ED at their own risk, meaning they leave because they haven't had their needs met. That's an extraordinary fact. And of course, they're much more likely to arrive by police or other non-health service vehicles, indicating the extent of the crisis they're in. And that's a failure of what they haven't been able to acquire in the community, what they haven't been able to receive, have access to. That summit agreed on the need for reforms, and we were asked to present or prepare a paper for ASM to use to aim to meet those needs through reform. As Nicholas has said, we have disjointed incrementalism. We often don't have incrementalism. We have one step forward and another step back. We pilot things and don't continue them. Nicholas has said all that. I won't keep emphasising it, but it is really important. So this report was done 4 years ago. One of the things that really distresses me at this end of my career is that really good work is repeatedly repeated. Nicholas and I have done some very similar work. None of it connects. None of it becomes powerful enough to lock in change. We do see change. I'm delighted by the improvements or the focus on improvements in primary care. And that will add something of merit, but it is so slow, as Nicholas said. We need reports like this one that we did 5 years ago to be working. But there's no one left in that college with the history of this report either. So these are the problems. We have really, really good evidence. We don't need more evidence. We need a collaboration for change, which is what I've tried to achieve here at Victorian University with the Australian Health Policy Collaboration. But it needs commitment of people as well as commitment of funds and commitment of support and commitment of an institutional background. So I urge you to think, if you want to see change, how to get there. And I will talk a little bit about the Being Equally Well report, because I think that's just as relevant to your discussions today as this one is. So the health system context. I don't need to repeat any of this. Nicholas has summed it up extremely well. The main thing to realise is the need is urgent for a comprehensive approach to system improvement. And not just for people with mental illness, but particularly for them because of their significant disadvantage. EDs around the world have had a high increase in recent years. 2 decades has seen a big increase. So are we becoming much more acutely ill, or is our health systems constantly trying to patchwork across an ancient model? And it is an ancient model. Hospitals were designed to meet acute needs and infectious needs and trauma. We've gone a long way to eliminating the physical trauma of road accidents and the like. We've gone a long way to eliminating the infectious diseases, with the exceptions that we've had recently. We've done nothing to build the chronic care system, which is now what we live with. We don't die younger to the extent we used to. We live with chronic health conditions that are preventable, many of them. But we don't have a system for work for those. So, and limited inpatient mental health beds, because we have reduced investment in mental health care on the basis that the evidence community care is better is strong, but we haven't provided that continued community care. So the report found, this is a simple summary, the report found all that you would expect: lack of coordinated appropriate services, payment systems that rely on fee for service, not on coordination of care and on health outcomes, health services systems that are based on supply rather than demand, that lead with poor integration and poor accountability. I am repeating what Nicholas has said. And disturbingly, in the Australian context, significant underfunding that persists across many health services, and in particular community mental health services. And I have made that point. The other contextual issues for this is the workforce. We have a very skewed workforce, much lower numbers and ratio of medical specialists of all kinds in rural and remote communities and less advantaged communities. Similarly, fewer general practitioners, and troublingly, that rate of decline is increasing. And we have most of our major hospitals in central locations, or locations that once were central. We have really limited funding arrangements. They are, as Nicholas described, often time-limited, grant-based, subject to a political decision about renewal, which means that they are not part of the health system. They are that orange lozenge he talked about. They are also always, in history, poorly funded. I think one of the things that I have watched in my career that was really badly done in policy was the transition from mental health institutions to community-based living for people with mental illness. We deinstitutionalised and we did not build a comprehensive community health system. Nicholas talked about the issues being similar in aged care. I began my career in this area in aged care and spent 20 years working firstly with the Australian Council on the Ageing and then the Victorian Department of Health, focused on building aged care services that were appropriate for people in the community. And in the 80s, at the time of the Hawke-Keating government, the reform of aged care was one of the most remarkably sensible, well thought through social and health policy changes I've seen. Instead of deinstitutionalising abusive aged care institutions, which had been identified in the Senate inquiry, very similar to the recent Royal Commission, that government started by building a home and community care program, providing the community support to help people stay in their own homes rather than move into residential care. That program rolled out for 3 years, and I was party to it from the Council on the Ageing before the residential reforms were begun. And then I became part of those. Mental health went the other way, but the community system was never built. That's a really major issue in what this report looked at. Funding is a big issue. The cost of providing emergency health care to people in mental health crisis is significantly higher than any other cost. So why do we allow it to go on when we're normally driven by the dollar? Nicholas made the comment that one psychiatrist stopped a community integrated care program from working properly. We have professional territories that we have to overcome because they stop politicians quicker than anything else. What's the downstream consequence of all of this in the emergency department? When hospitals have someone in their care in the emergency department and they can't find a bed person stays longer and longer. As I said earlier, often leaves at their own risk. It's extremely hazardous, clinically, mentally, and physically. It goes without saying that the person in crisis is in a very unhelpful environment in an emergency department. And said carefully, because we weren't asked to do clinical quality evaluations, it does look as though the care is suboptimal. So what did the report recommend? These are motherhood statements that Nicholas has also articulated. We have to have adequate services. We need improved funding and service models. We obviously need effective services coordination and accountability in every jurisdiction. We need to ensure best practice emergency mental health care and treatment. And we really do need to invest in rural mental health services and workforce capacity. That is now getting attention in the primary care sector, and that's the important place to start. But all of these things have been known for a long time. We were not asked to describe what should be done. We were asked to identify what should be done for the college to take it further forward. However, what do these recommendations mean in real terms? So we did spell out what that looks like. And the other report I've referred to, Being Equally Well, which also comes up on a Google search and is on Victoria University website and on the website of Equally Well Australia, lays all this out in much more detail. And we did a very comprehensive system analysis and proposal of system redesign, which includes a national report to health ministers on outcomes for people with serious mental illness, annual national report. It includes a clinical registry and an office in the Australian Quality and Safety Commission to lead quality improvement in integrated care. We didn't use that term, we called it coordinated care for people with serious mental illness, focused on their physical health needs. That's what Being Equally Well means. And it too, if that came into place, these issues in emergency departments would reduce significantly. So this report said, state and territory strategic needs assessments to identify the requirement for patient mental health beds in line with international best practice evidence and standards. And way back in time when I was working in the Victorian Health Department, we set planning standards, population ratios, bed population ratios. They weren't ever met. We need additional resources for step-down beds, step-up services, short-stay units, hospital in the home. There have been multiple reports recommending these things, not just in mental illness, in physical health care as well, in palliative care, where I have done some work. We know what we need, but it bears repeating because people like you need to take this forward, and you may not be familiar with these concepts. They need to become part of your everyday thinking. We need innovation funding. We need funding that is not tied to particular types of narrow programs. We need the commissioning that is now possible through primary health networks to be more extensive, to enable coordinated care models to develop that fit local communities, because every community has different resources, different needs, to provide ongoing and sustained care. We have to have a strong system shift. Current government is absolutely focused on building the primary care model. That is its business. States lead hospitals. We need a National Health Services Commission where the Commonwealth and states could actually work together on the same thing instead of on the same thing separately. We need innovative diversion or alternative care models. Nicholas gave you examples of services that have been trialled and tested and implemented overseas. We don't need to invent anything new. Everything good is being done somewhere. We need to cherry pick. We absolutely have to invest better in public health funding for mental illness, and sadly that debate is running in Melbourne right now because of an awful experience in the city with clearly someone who is identified as having a mental illness. We need publicly funded mental health services to work properly, to provide the care that people need in order for all of us to live safely, including the individuals. We need mental health expertise in emergency department staffing. That's obvious, as it's now the only place to go when there is nowhere else to go. And until we build the other places to go, it has to be extremely well supported as the final destination. I had hoped Dason would take that forward as a major campaign, but colleges change people every 2 years with the leadership. Memories go. It's just like politicians, really. We've got the same problem in the health sector as we have in policy sector. And we need plans like centralised follow-up services in all jurisdictions for people who are discharged from emergency departments. It's an obvious shopping list, nothing particularly new or different in that. Unlike Nicholas, I have a strong view that primary health networks are the hospital the Commonwealth has always needed. The Commonwealth role in health is remarkably to pay small businesses to do things. It's what general practices are, that's what pharmacies are. And they are its major two contributions to healthcare other than public health safety. So the Commonwealth has needed something that would allow it to start to shape the way small businesses connect with public businesses, with other private businesses. And primary health networks finally have the structure that is needed for that to be possible. We have slowly walked our way through divisions of local general practice, which were in some cases really membership clubs. We then went to Medicare locals. We now have primary health networks. All three have had the same pattern of some really dynamic leading groups and others that just plod along. It's how to harness the leading groups to try and achieve system change. That is one of our questions. But the commissioning model that primary health networks have is really the first chink, the first wedge into the system where Commonwealth funds could actually deliver coordinated community care, or even a coordinated care platform, connection between acute health and primary care, something in the middle so that people with broken arms don't need to go to emergency departments. Urgent care clinics intended to fill that gap. It's a long road to invest in 50 urgent care clinics and hope that the system will be fixed. We've got a long way to go. We need something more than just more clinics. We need coordination between the Commonwealth and the state. That has to be achieved by bodies that are set up to work in regions and nationally. And we need a proper national standard for mental health services. And the rest. I will leave you to read the rest, because this is quite detailed and it's not new. It's just collating what the evidence says needs to be done and has been done somewhere else. I'll leave it there. Thank you very much.